more than twice as likely to develop recurrent and persistent types of depression. And this is true, as I said, both for recurrent type of depression and also for persistence. So maltreatment may be associated with a specific type of depression that really contributes to the large health burden related to the condition. But even more, I was interested to explore whether or not maltreatment could be also associated with treatment. So this is just a brief reminder of how depression is treated. And here I'm using some UK guidelines, but American guidelines are actually quite similar in this. Adults are generally treated with psychotherapy, be it cognitive behavioral therapy or interpersonal therapy for mild cases of depression, and pharmacotherapy for the more severe cases, generally in combined treatment situations. Young people are generally treated with psychotherapy, different types of, for any severity of depression, and then might be treated with medications for cases where the psychotherapy alone is not effective. And the take-home message from this slide is that the combined treatment, so psychotherapy and pharmacotherapy, is effectively our best way of treating these severe cases of depression. Again, this is interesting with relationship with what I just told you about inflammation. So what I'm showing you here are the results of trial of amitriptyline, a tricyclic antidepressant, which was given to patients over an 8-week period. And what you see here are baseline levels of inflammation. So what the researchers have done is conducing this trial and then using some of the baseline bloods that they had collected prior to starting on medication, patients on medication, to predict which patient would be responder or non-respondent to that treatment. And what you see here, again, this is one of the first studies, and a few others have confirmed these findings, is that depressed individuals who responded to pharmacological treatment seem to have inflammation levels that are similar to the ones of controls, whereas non-responders seem to have much higher levels of inflammation. And in this case, we're talking about the pro-inflammatory cytokine IL-6. And so I went back to the logic I just told you about. I thought that if maltreatment is associated with high levels of inflammation and inflammation is associated with treatment resistance, then perhaps maltreatment might also be associated with treatment resistance in depression. And similarly to what I did for the epidemiological studies, we undertook a meta-analysis of trials of different types of treatments for depression, predicting whether or not maltreatment could be used to identify those with worse or better outcomes. And these are, again, the results of the meta-analysis. This is a different one, but now you know exactly how to read everything. And so if you, again, want to start from the bottom, the red diamond on the bottom tell us that overall, depressed patients with a history of maltreatment are more likely to be responding poorly to treatment compared to depressed patients who did not have a history of maltreatment. And if we do then a breakdown of these results and look at different types of treatment, you see on the top we consider psychotherapy alone. And as far as psychotherapy alone is concerned, we don't really see significant difference between depressed patients who had or had not history of maltreatment. For pharmacotherapy, you see that we're starting to see an effect where depressed patients with a history of maltreatment had poor outcomes. And what was striking to us was that if we look at then the combined therapy, again, this is the form of therapy that is most effective in the severe cases, or should be. Here we see really the most clear effect of maltreatment. And in this case, we see again that depressed individuals with a history of maltreatment were almost twice as likely to have poor treatment response. And this is with the most effective form of treatment. And this to us really suggested that more needs to be done to understand the pathophysiology of depression in maltreated individuals, and also to identify alternative pathways through which this type of depression could be addressed. So summarizing, again, maltreated children are at elevated risk of developing a specific subtype of depression that is associated with the largest health burden, that is recurrent and progressive episodes of depression throughout the life course. Also, depressed individuals with a history of maltreatment are at elevated risk of poor response to a number of different treatments for depression, and particularly, they seem to benefit less for the most effective form of treatment. So what I hope I managed to explain is that we have been aware for long about the mental health and also physical health toll that is associated with maltreatment. It is important to understand how maltreatment has this sort of health effects. And inflammation might be one of the pathways that contributes to these health effects. What is important is that if we identify these effects, be it inflammation or any other effects that we will find in the future, we will be in a better position to also think about new ways to treat what are difficult cases to treat in the clinic. And building on this idea, I want to finish by showing you one of the intervention studies that have been done targeting the inflammatory system in depressed individuals. What you see here, if first of all you focus on the right-hand side, is a comparison between individuals with treatment-resistant depression that were treated with infliximab, which is a TNF-alpha inhibitor, so an anti-inflammatory drug, and placebo. What you can see is nothing. It is a very disappointing result to begin with. What authors have done is then going back to the sample and try to understand whether the effectiveness of the treatment, the efficacy, I should say, of the treatment was different based on the initial inflammation levels. And this is what they found. If we look at the group of patients on the left-hand side, these are the ones with low levels of inflammation to begin with. In that group, giving anti-inflammatory medication didn't really make a big difference. However, looking at those in the middle, so these are the patients with high levels of inflammation to begin with, in that subgroup, they started seeing some effects that I know they will want to follow up with larger planned analysis. But this highlights the idea that if we can identify those patients with depression who are in this central group, we might be able then to have another way of treating these treatment-resistant cases of depression. And as I explained, we think that maltreatment might be one of the factors that can help us identify individuals in the population, and particularly depressed individuals who have high levels of inflammation. So I want to finish by thanking many members of my team, collaborators in the Dunedin and the ERISC study, and thanking you very much for your attention.
So we actually have time for a few questions. There's microphones on the sides.
Hi, Andrea. Can you hear me? Thank you. That was a great talk. I'm wondering about this regulation of the inflammatory of inflammation. So rather than increase inflammation, decrease inflammation in individuals that have chronic depression and repetitive episodes. Any thoughts on that?
So you're saying low inflammation is associated with this?
Yeah, an inflammatory system that instead of being elevated is not working right. It starts to become dysregulated after recurrent episodes of depression.
Yeah, so you're thinking about upstream ways of regulating inflammation, or so it's possible that Well, there are a number of mechanisms that can regulate inflammation and that can also be affected by repeated episodes of depression. And for example, it could be obesity, could be other health behaviors that are associated with depression or stress itself. So the more episodes of depression you will have, the more episodes of high perceived stress you will have as well. And so this cumulative exposure may, over time, in some ways sensitize the system so that even smaller or milder forms of stress may then trigger episodes of depression. Does that?
But do you think also that the opposite may occur where the actually inflammation does that the system stops functioning?
Absolutely. So, well, first of all, let me say, what I showed is that some cases of depression might have an inflammatory pathophysiology, but of course, I would never say that inflammation is either necessary or sufficient to cause depression. It could be that if you give very high levels of inflammation, so like with interferon alpha, many patients will develop depression, but 50% of them will not. So it's just one of many probably correlated mechanisms that could be explaining this association between early life stress and depression.
Good morning.
Good morning.
I have to admit I am not a biological scientist, so some of my questions may sound a little,
Well, thank you very much for just sticking there and being exposed to all that.
My first issue is the idea of exposing children to certain drugs that may affect the makeup of the chemicals that come out of their brain. You mentioned that in order to combat inflammation, very often it's the brain that's causing the inflammation to begin with. So what mechanism are you using when you give these drugs to children to try and reduce their inflammation? And what's the mechanism that is actually reducing the inflammation, and how is that reflected in your study?
Yeah, absolutely. That's an excellent question. So I should say, first of all, that I'm not giving anti-inflammatory medications to maltreated children. I'm interested in understanding the mechanisms for a number of reasons. One is to highlight these systems. And then the other one would be to try and understand how we can modulate these systems. So your question is really spot on in this second point. I think it is possible that some of the medications we are using already might be helping, modifying the inflammation levels as well. So for example, medications such as SSRIs, we know have some effect on inflammation. But I think more importantly, I'm not saying that necessarily we need to do something pharmacological to treat these problems. I think we know quite a lot about how cognitive, affective problems are related to maltreatment. And what I'm particularly interested in is, for example, seeing whether treatments that we know are effective or we can measure are effective in the clinic also modify inflammation. So it is quite possible that I'm not suggesting necessarily a drastic revolution in how we treat depression, but that we measure the mechanism through which the treatment effects arise.
And one last thing, are you an advocate of individuals who try and stimulate, and I'll just use the generic phrase, play centers of the brain that may be of benefit to a child who is going through a traumatic experience? Do you think that there is an opportunity for that brain chemistry to be activated through activities which bring joy and happiness to the child?
Yeah. So I suppose I'm not fully aware of any study that have showed that these type of activities bring on lasting changes that could modify these systems. So I wouldn't be an advocate for those.
One last question?
Hello, good morning. I was interested in the slide you showed about how non-responders to treatment had increased levels of IL-6 prior to treatment. It's my understanding that IL-6 exists in pro-inflammatory and an anti-inflammatory form. I believe it's the soluble form that is pro-inflammatory. I was wondering if you looked at differences in the soluble versus membrane-bound form of IL-6.
No. And I think IL-6, as measured in the plasma, generally has, particularly if it has a chronic sort of increased pro-inflammatory effects. But I think this is one, as I was saying, of the examples of different biomarkers of inflammation that can then predict treatment outcomes. So because of the construct of pro-inflammatory mediators, I would say that is more likely that pro-inflammatory levels at baseline will predict treatment resistance.
Okay, thank you very much. Great talk, thank you, Andrea. It was a nice example of combining basic science and bridging that to clinical treatment. Okay, so we continue our discussion on immunology with our next speaker, Dr. Hannah Schreier. Hannah Schreier completed her PhD in health psychology, working with an excellent group at the University of British Columbia in Vancouver, Canada. She then moved to New York, where she spent 3 years of her postdoc in Mount Sinai at the Department of Pediatrics. And just a few months ago, she joined Penn State in the Department of Biobehavioral Health and also the Network of Child Protection and Wellbeing. Hannah's research is focused on understanding the influences of adverse experiences on markers of chronic inflammation. And she's also interested in exploring the use of social interventions to actively improve physiological outcomes among adolescents. Hannah?
Good morning, everyone. Can you hear me all right? Is this working? No? I'll move this up and try to speak more loudly. Okay, hopefully this is better. All right, so I want to talk about two fairly different topics during my talk today, as you can possibly tell from my talk title here. And so first, all right, we'll continue in the dark. So first, I want to talk about the idea that the biological consequences of child abuse carry forward don't stop with the individuals who were directly exposed to child abuse, but carry forward into pregnancy and have potential consequences for the next generation that we don't clearly understand yet. And then partway through my talk, I'm going to change gears a little bit, or a lot actually, and talk about some ideas for possible interventions, specifically social interventions that we might be able to use to actively improve physiological outcomes of interest among adolescents. And so I'll start. All right. Sorry. Is it better if I hold it like this? All right, so hopefully this will help. Still shaking it, okay. I'll just try to speak as loudly as I can. So I'm still also recovering from a cold, so my voice is limited. So I'll start with a little bit of background on the HPA axis, and I'm assuming that most of you are fairly familiar with the basics, so I don't want to spend too much time on this. But so very briefly, the HPA axis, of course, stands for the hypothalamic pituitary adrenal axis, and it's the body's stress response system. And so what happens when you perceive a stressor in your environment is that the hypothalamus signals through the release of corticotropin-releasing hormone to the anterior pituitary to release ACTH, which in turn then leads to the adrenal cortex increasing the production and release of cortisol. And so cortisol is often referred to as a stress hormone, and it is involved in the activation of the physiological stress response, but it's very important to remember that it's also involved in all sorts of different aspects. So it's also involved in learning and memory and emotion. It's important with respect to regulating the metabolism, especially glucose storage and glucose utilization. And as we've already just heard, it's also very important with respect to regulating the inflammatory processes that happen inside of our bodies. And because of the involvement of cortisol in all of these areas, understanding maternal HPA axis functioning during pregnancy is of particular interest. So first of all, we know that maternal HPA axis functioning during pregnancy, if there's a dysregulation of HPA axis activity, that can be associated with detrimental effects among the offspring, such as lower birth weight. And we also know that the maternal HPA axis is very important with respect to programming, if you will, the HPA axis of the next generation. And so at this point, it's important to just briefly mention that there are many different types of stressors, and that the HPA axis response that we see in response to stressors varies depending on different stressor characteristics. So it matters whether stressors are acute or chronic. It matters whether they're being perceived as controllable or uncontrollable, and it matters how severe they are. So in general, and this is a gross overgeneralization, but what we typically see is that acute stressors such as public speaking or being asked to perform mental arithmetic in a laboratory setting acute stressors tend to be associated with a short-term increase in cortisol, and then chronic stressors also are associated with an initial activation of the HPA axis, but then if they continue over longer periods of time, what we often see is a flattening or of the cortisol profile or a blunted cortisol response. So if you look at this graph at the bottom here, this is not actual data, it's just a heuristic, but if you look at the solid line, that's sort of the kind of typical daily cortisol response that we expect to see in an average healthy adult, where cortisol peaks about 30 to 45 minutes following waking, and then declines over the remainder of the day. And if you look at the dotted line, that's the sort of blunted cortisol profile that we might see among individuals exposed to chronic and ongoing stressors. And so with all of that said, I now want to talk more specifically about the effects that child abuse and lifetime trauma can have on HPA axis activity during pregnancy. And I want to focus specifically on cortisol measured in hair rather than in saliva, because that allows us to consider a time span more in the range of weeks to months as opposed to minutes and hours. And so I've already mentioned that cortisol during pregnancy is important because of potential consequences for the offspring, but another interesting thing is that the HPA axis activity actually changes over the course of pregnancy. So in this graph, you see average hair cortisol levels for each of 3 pregnancy trimesters from a sample of women, and then again from the postpartum period. And you can see that there's a linear increase in hair cortisol over the course of pregnancy, and that hair cortisol then declines again following delivery. And so we know from a number of studies that experiences of child abuse and other trauma have an impact on HPA axis functioning, but almost no studies have looked at those associations among pregnant women. And so one exception to that is a small pilot study that considered the effect of child abuse history on maternal cortisol response during pregnancy. And so what they found in this study was that later on in pregnancy, so around 35 weeks gestation, the women who were exposed to child sexual abuse, but no abuse or different types of child abuse, showed an increased cortisol awakening response later in pregnancy, towards the end of pregnancy. So you can see that within the first hour following waking, these women basically spike higher in terms of their cortisol levels. And so for the study that I'll show you some data for now, what we were trying to do is we really wanted to focus on HPA axis activity throughout all of pregnancy, so that's why we focused on measuring hair cortisol. We also wanted to recruit pregnant women from diverse racial and ethnic backgrounds, first of all because women from minority backgrounds are often underrepresented anyway, but also because we know that rates of childhood abuse and trauma are often higher among women from racial ethnic minority backgrounds. And then finally, we wanted to look at the association between child abuse history and hair cortisol during pregnancy.